I want to first say to everybody, my name is Daryl Denard. I'm with 100 Black Men of Chicago. I also serve as the host and producer of iHeartRadio Chicago's public affairs programming called Chicago Insight, as well as Chicago Speaks. Chicago Speaks airing on V103 on Sunday mornings. It is a pleasure to welcome you to the 100 Black Men of Chicago's COVID-19, A Black Perspective. We're joined this evening by Doctors Terry Mason, who is the former COO for the Cook County Department of Health, as well as Dr. Garth Walker, who is an emergency room physician with the Jesse Brown Veterans Administration Hospital. I want to welcome all of you here and first give our audience that are tuned in right now via Facebook Live the understanding in terms of what we're trying to do. The purpose of this critical series is to hold a series of virtual town halls. We will do this every week, subject to a time change, and it's to activate as well as to empower the Black community in response to the coronavirus pandemic. We wanted to start out by hearing from two of the leading voices as far as medical voices that we respect here in the community, and that's why we have both Dr. Mason and Dr. Walker joining us. I guess I want to first start with a little bit of age before beauty, and and begin with Dr. Mason and give us an overview in terms of where we are with this coronavirus pandemic, beginning, I guess, starting in Wuhan, or there may be new information. Dr. Mason.
Well, thank you very much. And I want to add my thanks to the 100 Black Men for pulling together this kind of forum. I think it's great that we're doing it. And I'm glad to see that we as men are taking a position of control and helping to shape and define exactly what this means. Much of what you've heard about the coronavirus, obviously being a virus that many people may not know that these viruses, most all the viruses, jump from animal vectors. That is, they're normally found in animals and then they end up in humans. And so that's why many of our flus and many of our diseases, we call them, whether they're avian flu or they're called bird flus or they're called just any number of things. This one happened to come, there's a lot of different things, but happened to be a vector in an animal called the pangolin. And at least the story goes, and it was trafficked all over the world because these particular animals were trafficked all over the world for their kind of scales that were thought to have some male sexual enhancement properties. And so these things were trafficked all over. Obviously, a bat bit the pangolin, and this whole situation ended up in a virus that was normally in an animal vector that then mutated to be able to be spread to humans. And the rest is history. This particular virus, though, and I'm sure Dr. Walker will get into more of the medical situations behind it, but from a public health perspective, what the virus has done is exposed a severe weakness in our society, so that people who've been marginalized, you got to remember, if we look at just the history of how we've come to this country and how we've come to this city in terms of where we were concentrated in certain areas and how we've had to live in areas like the projects and how we've had to live in areas where there's not the kind of infrastructure that needs to be there, be it clinics, hospitals, grocery stores, those sorts of things that have always contributed to the underlying causes that is creating such a death situation now with us with this particular virus. It is those people who are complicated by so-called heart disease and so-called diabetes and so-called other chronic diseases. And I say so-called because as many of you know, the data that I read shows that most of these things are dietary caused. And I can also show that it's nothing different than what we see when we look at the lifespan between somebody that lives in Streeterville and somebody that lives in Inglewood. There's a 60-year difference in the lifespan of people that live in Streeterville, which can live to 90, versus people who live in Inglewood. We've seen this over and over in public health literature, including the food desert studies that looked at income, not only just here in Chicago, but in places like California, where looking at two groups of people that live in Oakland, where there's a difference in life expectancy in terms of not life expectancy, but in terms of the likelihood to die of 70% from the people versus the people who live in better areas. So all I'm saying is that what COVID has done is expose the social determinants of health that have created the differences in life expectancy. Black men die more from heart disease, more from strokes, more from cancers, not because we're Black, but because of the circumstances, whether it's been in housing where we were exposed to different types of gases, or whether it was just that we didn't have good jobs and could not take care of our families, or we were exposed only to places where we couldn't get good food. And as a result, these things have created these underlying conditions that complicate the severe respiratory disease that COVID-19 is causing. We don't have a medication. We don't have a vaccine. And so in terms of what we can do is merely supportive things. The three things that we always talk about: clean, cover, cough. Everybody's talked about that. And the other thing I would say is, even though our immune systems have not seen this virus because it's new and we have no immunity to it, we still rely on our immune system. And so the two things I always talk about in terms of strengthening our immune system as best we can: manage our stress, get our sleep, and we need to enrich our bodies with more antioxidants. And those things come from fruits and vegetables, not from things that walk, hop, crawl, swim, fly, or slither. So we need to eat more fruits and vegetables, more of them in their natural state than ever before, because right now our good offense is a good defense, as best as we can make it.
Well, that sounds good for that social medical description in terms of why we're marginalized, and also why we suffer from what many call dramatic disparities with regard to the impact of COVID-19. I want to flip the script just a little bit, Dr. Walker, in terms of your perceptions being on the front lines there over at Jesse Brown Veterans Administration Hospital. I know that you're new to the profession, and even though one of the best defenses that we can employ, that I definitely would agree with Dr. Mason, in addition to diet, is also getting proper rest to de-stress the body and to rejuvenate it. You're a person right now, I'm sure, that's hardly getting any rest. And what is it like on the front lines there in terms of people literally filling emergency rooms at hospitals across the state, across the country, across the world for that matter, suffering from this ailment?
Sure. From an emergency medicine perspective, in general, right now, a lot of our census are low, meaning that a lot of hospitals are shutting down their outpatient centers. Most of our presentations are focused and being prepared for the COVID crisis. So that means opening up new space that can be for ICUs, that can be able to sustain the new influx of presentations of respiratory conditions. So from that standpoint, it's different from our typical day-to-day. And even that gives me a little bit of pause. Usually we're used to heart attacks, strokes, things of that nature. And one of my major questions is, what are those patients doing right now? And when it's respect to our community, what we want to know and what we want to make sure that we understand is to make sure that they're getting their medications, make sure that virtual health is penetrating our communities appropriately, so that we know that our community is being followed up with our day-to-day activities that keep us healthy. So that's one thing that we need to make sure that our communities are doing. With respect to the virus, it's a little bit atypical. So for example, I will see a young patient that is oxygenating around 92%. That's not normal. Typically, somebody my age will be around 98 to 99%.
You're
So
currently you're currently oxygenating at that time, at 92%?
no, patients that have the COVID virus
Are
will have,
oxygenating at 92% when we should be at close to 100, correct?
yeah, and I'm talking about young, healthy patients.
Wow.
So that's abnormal for us. And usually what we end up doing is having them walk around to see how far low it really goes, and ultimately admitting them to make sure that we watch them. But with respect to other issues, our community is not just vulnerable specifically because of the medical condition. Obesity, heart attacks, hypertension, those things are not new. They don't discriminate by race. I want to echo the role that social determinants of health plays within our communities. Just because, if you go home and you live with 5 people and 2 of those people have multiple medical conditions, how can you actually socially and physically isolate? It's very difficult. So we have to make very unique recommendations to our community. And so oftentimes what I'm telling my patients when they visit our ER, I'm trying to see, is there other ways or other situations where we can put the most at-risk person in a safer environment, which could be moving in with another family member. Or if you have a lot of family members that are essential workers who are consistently exposing themselves to the virus when they go outside, are we making sure that they have masks? Are we making sure that they have the appropriate equipment? And if you do have to go grocery shopping, how many people are going out to do that task? Try to send one person out so you don't have multiple people exposing themselves to the virus.
Now that's an interesting piece of advice there, because many times, you will have your partner with you and both of you have the understanding that you're testing negative for COVID-19. And you say, well, this is an opportunity to go out together. And so you're suggesting, no, let one go out and the other stay at home.
If it's something like going grocery shopping, where you could go to a high density region where the virus can spread, the reason why it's so dangerous is because asymptomatic individuals can spread it from person to person. So I'm asymptomatic, meaning that I'm not coughing, I don't have a fever, I don't look sick, but I could have the virus and cough and wipe my mouth and pass it on to a doorknob and pass it on to somebody else. So what we want to do is make sure that we reduce our exposure to the virus, so that we can make sure that we're not implicating more people within our household. As Dr. Mason said, what this virus has done is show just how fragile our system is, how fragile our communities are. So just having the virus and exposing it to our community with the level of social barriers that our community faces puts us heavily at risk. So what we need is to not only educate our community, but also make sure that our state and government levels are thinking differently about our communities and providing the appropriate resources.
One thing that I want us to think about as we answer questions, not only from me, but also from people that are joining us right now on Facebook Live. Once again, if you're just joining us, you are listening to a town hall, a video town hall sponsored by the 100 Black Men of Chicago, called COVID-19, A Black Perspective, designed to talk about the impact of the coronavirus on communities of color, particularly Black communities. And we're joined in this discussion by Drs. Garth Walker as well as Dr. Terry Mason. And I want us to give out advice. We heard from Dr. Mason talking about the necessity to bring more natural things into our diet and to be much more conscientious about staying away from not only, of course, processed foods, but also from meats that we as Black folks tend to love. And then the other advice that I heard from you is something that we definitely can employ, because it's something that I did. And that is, yeah, I like my wife to be with me, but at the same time, it's probably wiser if just one of us goes out to these essential errands that we must do, because it lowers the amount of contact that we have with regard to exposure of the aerosol virus. I want to, in terms of Dr. Mason, talk about the efforts and how advice and Black people, particularly Black men, we're of course representative of that, being members of the 100 Black Men of Chicago, but an inclination far too often in terms of not following the advice of leading health authorities, whether it's the CDC or people from the state of Illinois' Department of Public Health, or Cook County Health Systems, or the City of Chicago Department of Health, in terms of what you suggested in terms of clean, cover, and understand the cost. But we're supposed to practice safe distancing, but yet, let's be real. I live in my community. I frequent, and I don't do it anymore, but if I'm driving through my community, you see far too many areas where Black men, in particular, young Black men, are huddling together. They're completely disobeying the advice with regard to social distancing of at least 6 feet. They're not wearing any type of protective gear over their faces. And they're just, in a sense, spitting in the face of advice. Why is that the case, Dr. Mason?
Well, I can't tell you why. I think sometimes young people believe they're invincible, that, you know, that's for somebody else. You got to remember there were a number of rumors floating around initially that Black people couldn't get this virus. Yeah. And so there are a number of other rumors that are floating around, whether we know what they are, believe it or not, but these are things that are also dealing with the psyche of some of our young people. The other thing that we have to
But young people are dying.
That's true. Yeah, but you see, but we have, I was at our Stroger Trauma Center one Friday evening in the summer, between 3 and 7, we had 13 people come in shot. So that doesn't, the idea of somebody dying, and I hate to say it this way, is not as shocking as it should be for what's happening. But what the other thing I wanted to do is that, make sure is that, is one thing to criticize people about not having protective stuff on, but the question is, how easy is it to get? We've had some real snafus with regard to managing this whole situation. Number one, testing was way late in the game. We were way behind the 8 ball.
And we still are, let's be realistic.
We're still way behind the 8 ball in terms of testing. This is a major failure of the government to not have prepared, and we knew this was coming. We saw it coming from Wuhan, we saw it come from Italy, we saw it come. So it's not like we didn't know. So we didn't prepare in terms of having enough testing kits, in terms of having enough protective equipment, masks, gowns, the things that we need, pappers, that where we may need those, where you have the little fans that filter out the air. We were putting our frontline workers at unnecessary risk by not having these things in the proper levels of stock that we should have had them. And so this is, and if, you know, if they used to say, if white people catch a cold, Black people get pneumonia. And in our communities where we don't have the access to the kind of quality facilities that we need that could identify where they had the appropriate kinds of ancillary equipment, whether it be ventilators or what have you, and the number of people working there who could respond quickly to somebody who was beginning to crash or not do well. In addition to that, we left out our congregate settings, things like nursing homes, where when things, you know, one of the people have things up, people understand is that the virus is also in the stool. So if you're in a nursing home where you've got a lot of people, or in a homeless shelter, or in a jail, or in any of these places where you have lots of people in congregate in settings not that far away, it's very easy for this virus not only to be spread in the droplets when we sneeze, but if people are having diarrhea or having other issues in nursing homes, this is another way that this could be spread. And so we really, right now, are still behind the 8 ball, in my opinion, in the amount of testing that we're doing, and reliable testing, making sure that a negative is a negative and a positive is a positive, and not hold out for the promise of medications that are not going to be coming very quickly. There are a number of trials that are going on, but it's still going to take a while before a vaccine actually appears. So our people, everybody, and I don't think it's just young Black men and young Black people, it's people, if you look at what you see on television all over, it's people, it's white people, it's everybody that are doing their own thing from one point of view. The only defense we have against this is try to keep people that are infected away from people that are not. And that's all we have right now. And so until such time that a medication becomes available that has proven efficacy, in other words, it works and it doesn't cause more harm than good, we are still sort of behind the 8 ball, and we just have to do those things that we know work, like the social distancing, whether we like it or not, and to make certain that we are taking care of ourselves, as I talked about earlier. We have to understand that the government, though, and I don't like to just jump on that all the time, but you got to remember the conditions that made the situations bad for Black men and women since we've been here are still not working on our behalf to improve those. Our social service systems, even some of the financial bailouts, all of those things have to be looked at critically as we go forward.
Dr. Walker, I know that you wanted to chime in there with regard to the initial question in terms of this almost Superman mentality or a sense of immunity that many young Black men feel, and Black women for that matter, and boys and girls.
Sure. In general, young people are not as affected compared to older people. So it's hard to feel how it might affect you. So yes, the inclination is to feel invincible. But I also wanted to tackle one point about kind of the therapies that have been suggested. Some people may have heard it from the president, but one of them being hydroxychloroquine.
Yeah, which proved to actually kill more people because of the resident side effects that exist with taking the disease in a coronary sense. But I'm not a doctor here, so please forgive me for interrupting.
No, you're spot on. So anytime you want to put forth a high-level study, one of the easiest ways to cut it short is if it causes more harm than good, and hydroxychloroquine definitely did that. It ended up causing more deaths or more severe complications. So first things first, there's no medication out here that can help this disease. The only thing we have is supportive or public health strategies. Vaccination will, at best, takes 12 to 18 months. Right now, they're running parallel trials to see if they could try to get it to 8 months. So it's from essentially now until then, the only thing we have is social isolation and waiting for the best strategy to put forth mass testing. And right now, the testing is only around 85% sensitivity. So that means 15% could think that they're fine, but potentially pass it. The last thing you want is 15% of people acting like they're healthy and transmitting the disease, especially for something like this, because all you'll see is a specific spike. And that kind of puts it into context when we talk about bending the curve or lowering the curve, because right now what we're doing is we're trying to keep it at a level that our hospital system can absorb, that we can handle. Like if we let people back out, we're just going to be, honestly, I'm going to be intubating everybody. That's how it's going to look in the ER. And the last thing you want is to visit the ER when it's inundated with sick patients, because now you start seeing poor outcomes in heart attacks, strokes, DKA. You just don't have the bandwidth to manage those things the way we typically do when there's a pandemic that is suffocating our healthcare system. So that's why
you have to give us a quick description or definition of DKA.
Oh, diabetic ketoacidosis, essentially
kidney
just an
failure.
emergency related to poorly controlled blood sugar. I'm sorry.
Yeah. And that is, it's really a prescription for disaster, particularly in light of what's happening in the state of Georgia right now. The governor of Georgia says in less than 24 hours, he's going to open up places like hair salons, barbershops, tattoo parlors, restaurants, places where by its very nature, it's impossible to maintain any degree of social distancing, which the recommended distance is 6 feet. And yet, he's a staunch supporter of President Trump, and even President Trump during his rallies that he holds on a daily basis there came out and said that he disagrees vehemently at one point with the governor's decision. And then you also have the governor of South Dakota that and I'm sure that Dr. Mason, as well as you, Dr. Walker, are well informed about this, said that in spite of the Smithfield plant, where I guess close to 50 to 70% of the workers there, some 600 people tested positive for coronavirus. And she said, no, we're not going to shut down any part of the state. And then she actually said, but we are going to sponsor a publicly funded test on hydrochloroquine. What kind of madness are we living in? I know Rachel Maddow had used the analogy Earth 1, Earth 2.
It's completely backwards. And I think one thing to keep notice of what you just said is the type of jobs that they're letting back in, or the type of jobs that they're allowing to go back to normal. It's not necessarily high income, high service jobs. So that's one thing that I think we should keep close watching, because we can't allow, it's a poor decision. We need to continue to isolate, and we need to continue to stress status among our most vulnerable communities and everybody around. But I am watching closely which jobs that they're putting forward to allow to go to day-to-day activity. Because honestly, if it ends up being the jobs that typically Black and brown people are doing day to day,
that's right.
It's going to be the same story. It's going to be the same story of 70% accounting for the mortality of the spikes, like Chicago or St. Louis or Milwaukee. So we have to be cognizant of that, but we also have to make sure we hold them accountable. But it's really frustrating right now because they're not listening to scientists. Fauci has been on point with his recommendations since he's been there, but he's clearly in a very difficult position. And it's dangerous, honestly, listening to these governors and presidents make the recommendations that they're making.
Dr. Mason, I know you want to chime in. Go ahead, sir.
No, I just want to say, Daryl, that it's reminiscent of a song Michael Jackson used to say, is that all I want to say is that they don't really care about us. That is one of the songs that Michael did. And that's really true about what we're seeing right now. And I think that what we need to do is take this as an opportunity to develop a resolve within ourselves and in our communities to understand that if we don't do what we need to do for ourselves, the cavalry ain't coming for us. And there probably has never been a cavalry that's going to come for us. So it really means that we have to take, and as men particularly, we have to take the responsibility for protecting our community from these other things and making sure that we're doing and advocating with our political officials, no matter who they are, with whatever is necessary. Because when you look at what's happening in the juvenile detention centers and in the jails and in a lot of these other places, and the congregate settings like nursing homes, these extended care facilities and all this sort of stuff where you have very vulnerable people, there are people who sometimes feel that those lives are expendable. And there's a thinking of that we have to always deal with. And then on top of that, we have to be more concerned about the people working at the front line like the gentleman that's just right here, sitting right behind you, that's been working in the emergency room at the VA, who is right there putting his life as well as the lives of people that he loves that are near and dear to him. But we really do need to begin to think about, because this is not just happening in America. This is happening all over the world. I've been talking to people from on the African continent and other places, and we need to really look at what this may really be. And I'm not going to put out any conspiracy theories or anything like that, but we do need to understand, and I'll just give this one quick thing, and maybe we could chime back in. But when you take somebody who's obese and they have a big stomach and they're laying down, where does all that go when they lay down? It pushes up against their diaphragm. And so what does that mean? That means they can't breathe as well. And even when you put a tube put a tube down their throat into their windpipe and hook it up to a machine that blows air into the lungs, that's what a ventilator does. If the diaphragm can't move down because the weight of the stomach and all the other tissues are pushing it up, then the ventilator can't be as effective as it would have been. That's why we have some of these issues. And when we already have some problems with our blood vessels being able to carry the nature of blood that we need, and it's already damaged, those lung tissues are already damaged by the virus, then even when you push air down, it doesn't, because the cells are damaged, it doesn't get into the bloodstream and give the necessary nutrients to the other parts of our body. So this is what's happening, and I'm not blaming us. We're victims in terms of this whole thing. I don't want that, and I don't want it to seem like we're dying more from stuff that we did. No, the obesity, the diabetes, a person dies every minute in America from a heart attack. Every minute.
Yeah.
And we don't talk about that at all. And obviously, if that's general, our situations are worse because of the historical differences and things that we've had to deal with, not just to mention the stressors. And so we need to take a renewed interest in how we fortify who we are as a people, and then begin to make sure that we love ourselves enough to do the things that keep us healthy. And those 3 C's are clean your surfaces, tables, what have you, cover. If you cough into a tissue. If you are sick, stay home. And those are the 3 things that we know we can do, in addition to the other things that we can, because until we get a medicine, that's all we'll be able to do.
We have a Facebook question from Loris, and she wants to know and have either one of you address the difference between asymptomatic and pre-symptomatic COVID patients.
I'll let my esteemed emergency room colleague.
Asymptomatic just means that you have the virus, but you're not expressing any symptoms, meaning you may not have a fever, you may not have a dry cough, you may not have body aches, you may not have this loss of taste and smell, which I've been seeing a lot in the emergency room. There's not really a phrase for pre-symptomatic. You either have the virus and you're asymptomatic or symptomatic.
Okay.
And Daryl, I just like to add that early on, one of the reasons we had a problem with testing is, see, the other thing is that we had nothing other than when somebody became symptomatic to begin to even refer them for a test. So if we had, and that was because we only had so many tests. If we had more tests available, we would have been able to test more people, because we really don't know how many people are walking around out there with the virus. We don't know. We don't know who they are. And so,
that is the core of the problem there, because I'm looking even with regard to testing. The World Health Organization had a test that they were employing in Germany, which by all accounts has done a pretty good job at containing the spread of the virus. And the United States refused to take that test. To me, shouldn't there be some sort of universal test that not only tests for the antibody to see if you have the disease, but also whether or not you had COVID and responded from it by still being around? And that's the part that I find a little bit misleading, because a lot of times people are lining up in droves to take these tests, And they're only getting tested for one thing, where if we were diligent about this testing thing, we would test them for multiple attributes of this disease. So that way we could have higher levels of data to tell us where it's happened, who we can look to that may have already had the disease and are doing very well right now. So we could use their bloods as a possible antidote. I don't know. But having all of these various tests seems to be, going after it with a very, very kind of crazy approach rather than having a universal testing system.
Well, Joe, the other thing is that we, in the beginning, and speaking now as a public health person, what we had were very limited numbers of tests. And then we had to wait for confirmation of any positive that we got from the CDC. That then slowed down getting a result.
14 days, if I'm not mistaken. It took 14 days.
Well, just think how many people can infect in that period of time. So that was one of the reasons why this thing, in my mind, got so out of control. And then we weren't focusing on some of the other things initially, because early on when we were trying to identify people, then we went and did what's called contact tracing. Contact tracing is, okay, I was with Daryl. Daryl, who were you with? Well, I was with person A, person B, person C, and then you go to person A, person B, person C.
Much like tuberculosis.
Then you find out who. That's all called contact tracing. And then that time, there's a big lag of time between all that happens. And we were talking about when you were with somebody who was symptomatic. Now, we didn't do anything wrong because that's all we had at the time. But I'm just amplifying if there was much more widespread, valid testing. Again, when we know a positive is a positive and a negative is a negative, then we could have done a much better job in trying to get ahead of this than we did.
From
Dr. Walker?
Sure. So I think there's 2 points. One is, we're not supplying the amount of tests that we need. There's also the component that we don't have the quality of the test that we need, meaning high specificity, high sensitivity. And essentially, when you want to test a large group of people, you want a very highly sensitive test, because that makes you know that you know it. What I did review the other day was tests that tested for IgM and IgG. So it tells you if you're active or if you have recovered. But again, the numbers are not necessarily there for us to feel confident that we can truly control it if we put it at mass. So it's a combination of that. But I think one of the more frustrating points that you just brought up was knowing that Germany had a high quality test and we choose not to. This is a public health issue, and politics should be aside from this.
Let's be honest. In terms of the president was touting the fact that we have all of these ventilators right now, a plethora of ventilators. But yet when it comes to testing, more than a month and a half ago, he talked about testing is not going to be a problem. Anybody that wants a test is going to be able to get a test. Here we are a month and a half later from that initial statement, and less than 1% of the population has been tested for this disease that has this crazy morbidity rate.
No, I agree. And especially when you know that vulnerable populations, Black and brown communities, are more at risk. My intention is to recommend that we test all our vulnerable communities, everybody on the South and West side, because it's completely unacceptable, especially from a public health issue. This disease will continue as long as we continue to neglect our communities.
Is a blood test really the only way to truly figure out just how infected you are in terms of whether or not you had it and you've done well, whether or not you're susceptible? I don't know. I know we're doing the swab thing now.
So it doesn't tell you how infected you are. It tells you whether you have the antibodies or not. So it gives you a lot of information, right? We can strategize around that pretty significantly if we have a good test that's able to tell you if you have it or if you've recovered. Because if you recover, presumably you won't get it again. But if you are actively sick, you can tell that person to isolate and not expose themselves to people who could be very at risk. So it does tell us a lot, but we just don't have that available. And if we truly want to get anywhere near to opening the economy, we have to be able to test a large proportion of our population.
Yeah, I know they're doing some great, making some great inroads in California right now with regard to testing. And that kind of leads me into our next question from our colleague, Art Norman. And he's asking that if you are hospitalized with COVID-19 and treated and released, what is the degree of the possibility of you being reinfected?
So honestly, it's too early. I haven't seen any studies that have showed reinfection or percentage of reinfection. What I do know is that co-infection, meaning if you came in with a respiratory issue and it's a virus versus the flu, it's likely that you have one or the other. But with respect to reinfection, there's no clear data out yet that gives us a confirmed yes or no. But the thought process is if you have antibodies, you're likely not to have the disease again.
Yeah. Dr. Mason, did you want to chime in there?
No, I think that Dr. Walker answered it just perfectly. I think that we need to realize the limitations of the things that we have and to set the right expectations for the things that we don't.
Yeah. Here we have a member of the coronavirus task force in terms of the director of the Centers for Disease Control, in a sense being forced to take back his comments that he made to the Washington Post, saying that if we truly don't address this thing now and stay on the track of employing social distancing across the country until we get this thing on a descending scale, that there's a possibility that reinfection could occur or respiking of COVID-19 that could be exacerbated by the regular flu season. And it was kind of miraculous to watch him trying to take back those comments without literally taking them back, because he had to say, yes, that is a direct quote. It's going to be devastating, but he used difficult as opposed to what his initial word was in terms of devastating. But time is the operative agent here, because if we don't address this thing right now with patience as a virtue, the reality of looking at the oncoming flu season and it not being sort of in control or under control a little bit, it's going to be a scary situation.
I would say it will be, because first of all, they clinically present the same way, at least early on. You can't tell whether it's regular flu. And you got to remember, regular flu kills about 40,000 people every year, and it's responsible for over 1 million hospitalizations. People get sick and die from regular flu. So the question is going to be, how will we manage that? And I think that when the only tool we have is social distancing. That's all we have. And so we have to continue to employ this in order, and people are making all kinds of financial arguments and all kinds of other things that are happening that have nothing to do with the welfare of people from one point of view. But we're already here. We've already done this for some period of time. We've made the accommodations in many cases for our children to continue to learn and do a number of things. Restaurants, though they're not serving food, you can still go and pick up food and bring it home if you wish. So I think to turn back now and not to exercise the caution that we know is the only tool other than God himself, that's the only thing we've got. And then to throw that away is absolutely asinine to me. So I would certainly argue for us to stay the course, because it is beginning to work. We are seeing some of the numbers beginning to go down in most places, and we need to stay the course. And we need to not let the politics and the optics and all this other stuff that has nothing to do with the welfare of people guide what we know the science will do if we listen to it and take heed of it.
Dr. Walker?
Sure. Another good point is that when we listen to people on the news, they're saying only this many died, only X amount died. But the truth of the matter is social distancing is the reason why the numbers are so low.
Mhm.
If as soon as you reopen the economy, our
Yeah.
hospitals will become inundated with respiratory presentations or higher mortalities. And yes, the flu during the wintertime is palpable as an emergency physician. I feel it, I see it, I test it regularly. And then what you throw on the COVID crisis is only going to become more difficult. And then our accuracy as a physician to see what people are truly presenting for can be thrown off because people present in different symptoms. So it will just be a recipe for disaster if we're not able to do something sooner than later.
Get a comment from a fellow member, Jeff Jackson, wanting either of you to comment on the efficacy or the efficiency of the various masks, and why is, I believe, N95 mask the one that we should try to place over our faces?
Well, I think that we from public health did not recommend N95s for the general public. Number one, they're still very difficult to get. And unfortunately, that's one of the barriers that we have, is being able to get these masks. I think that what we need to do is properly use whatever mask you have. And the reason I say that is because an N95 does you absolutely no good if you're not fit tested for it. So an N95, and we had them in the department, you have to be certain that you have the right seal. And the only way you know that is you have to be tested. Usually they use something that you can smell that you can't smell when you have the mask on. So that's called fit testing. So if you're not fit tested for the N95, it's not doing you as good a job as it could have been had you been properly fit tested for it. And if you've got a regular mask and it's not fitting tightly as it should, these things will not totally prevent. I mean, it's not 100%, but it's at least a helpful barrier. And the N95 is only as effective as it needs to be when you've been properly fit tested.
Now, Dr. Walker, isn't the mask also having the dual purpose of, if somebody is indeed a carrier of COVID-19, that the mask will at least stop or help to decrease the aerosol spread of the disease?
Yeah, of all the masks that you could get, N95 is the better. It's specifically related to the size of the holes related to the mask, so harder for the virus to penetrate. But there's also a dual purpose to just having a mask in general. People are less likely to touch their face, less likely to touch other items and touch their face. So that's kind of the overarching theme for why everybody should put something over their face in general. But the N95 mask, yes, that's why we use them in the ER, just because our exposure is so high. We also wear a ton of barriers before I see a patient.
And there are other things too that
face shields and
about this is what's called a PAPR. It's a positive airway pressure. It actually looks like a spacesuit with a fan that actually filters out all the air. And that's what we need to see more of for people, particularly on the front lines in the emergency rooms and some of the areas. And now, as we look at what's happening in our nursing homes and other congregate settings, the homeless and other things, we're going to have to be very, very diligent about how we maneuver in these circumstances. Because the one thing that I'm most concerned about is what happens when our defense system, that is our doctors, our nurses, our people on the front line, our people who have to serve food and pick food and all these sort of things, when they start going down in large numbers, we're going to have far more bigger fish to fry pretty soon. And we're not ready for that just yet.
We only have about 10 minutes left, and I want to talk about the importance of the research aspects of this. We want to send kudos out to Dr. Garger, who is a recent resident in terms of being an emergency room physician, if I'm not mistaken. And We need more Black people, Black men in particular, in the medical fields that are willing to service our communities. Sure, it's nice to have somebody that, and it's not taken away from the surgeons and the dermatologists and things like that, but we also need internists and people that are going to help treat our communities. And what we really also need, at least according to Dr. Loris Rayner, is a community that is going to research this disease. We need more people in medical research to come up with the strategies in terms of combating this ailment. How do you feel as a young Black man, Dr. Walker, in terms of what prompted you to, I want to be on the front lines of serving my community? And Dr. Mason, we know you did it a few years ago.
Sure. So I do research. I do research as well. I'm at the Buehler Center of Health Economics and Policy at Northwestern. So I do a lot of health disparities research, mostly around opioids and firearm violence. What led me to pursue emergency medicine is because it's one of the few specialties that you have to treat everybody. And oftentimes the safety net for most of our communities. And also really practical in terms of saving lives, doing interventions, and honestly just making recommendations in general. But I want to tack on to kind of what you talked about with research and why it's so important. Health disparities research is nothing new. We have seen the same outcomes for decades. Similar to lung cancer, heart attacks, the only difference is that you actually see people investing what the findings show. So lung cancer, heart attacks, we have increased life expectancies significantly. But when it comes to health disparities, social determinants of health, we have seen a lag in terms of the social and economic policies. So the importance of having more men of color, women of color pursuing this type of research, but also leaders in our community, in the private sector and nonprofit sector, advocating policies to address this research is already there, but we need to build the critical mass and make sure and hold people accountable. Smoking, obesity, all these things are not unique to African Americans. But we need to make sure that the social determinants of health are addressed. The research is there. We need to make sure that our social and economic policies are there to help reduce these social barriers that have been well documented going forward. And that's one of the motivations that why I do research, why I continue to do it, as well as why I continue to see patients.
What advice would you have? Go ahead, Terry.
No, I
mean, you want to say something, Terry?
Yeah, just real quick. I just want to say that, you know, my motivation for going to medical school was through a man by the Honorable Elijah Muhammad, who inspired me to go to medical school because he was trying to build a medical center for our people here in Chicago, and was thwarted everywhere he tried to build. When he tried to build it on what was over on King Drive, they made it Cole Park. When he tried to buy the cultural center, they made it the cultural center over on South Shore. And so and then I've also been involved with programs that help me, and that is the Urban Hope. It wasn't called the Urban Health Program then, but there are a lot of people like Linda Murray and other people for over 25, Olivia Patch, that have been on these committees for over 25 years along, and I've been on that committee too. And we've got the programs, they just need to be funded. And our students now need more money than they ever used to need, because everything costs more. The prep courses for the exams that you need to take, the medical school tuition is more. And then there's still emergencies that happen when people, their cars fall apart, or they got to get it fixed, and that trying to decide, do you take your tuition money and pay your tuition or get your car fixed? We have students now who are homeless. We have students now who are hungry, and they're riding the trains all night because they don't have anywhere to stay. This is a travesty, and we should not have that for students who are trying to work as hard as they can to manage a very difficult curriculum. And then we need to also, as a people, see a value to making sure that we're putting some of our own money and involving ourselves in these activities. So thank God for the National Medical Fellowships and those that do this, but we have to take some responsibility for ourselves because the cavalry ain't coming. There ain't no cavalry coming. We got to do this for ourselves, and it's appropriate that the 100 Black men of America are taking these steps to make sure that we are aware, but now we got to do.
I would be remiss if I didn't mention that April is National Child Sexual Abuse Prevention Month. And the reality is that many of the mandated responders in terms of being able to identify children that may be victims of sexual abuse are no longer able to communicate with these kids because they're not at school, they're not in after-school programs, they're not at church functions, and it's something that we need to keep, especially with the 100 Black Men of Chicago. That is our mission, to protect and to lead these young children. So I just wanted to put that out there, the importance of, if we see anything, that we need to say something. And go ahead, I know you wanted to say something there, Dr. Walker.
The only thing I wanted to say, all I want to say is that we as men have to step up and assume our rightful responsibility as men. When I was growing up, there were 23 Black automobile dealerships. Today, I don't think there's one. When I was growing up, we used to have 6 Black banks, and now I think there may be one. When I was growing up, every job I had, I worked for a Black man in a store or something like that. We don't see that anymore. We have to not ignore the elephant in the room, that we have more education. We have all the things that we need to do what we need to do. We just need to get it done. And we need to sit down, put our little differences aside, and do what we need to do to protect and be the men that we need to be for our community.
Dr. Walker, final comments.
No, I mean, I want to make sure that we keep the theme of thinking about our communities right now, what exactly is happening to our communities, putting forth the interventions that we need, eating well, working out, doing those things that can help improve our abilities in the future. But also, as we go more into a recession, as we go and recover from this crisis, I want to make sure that we are aware of where we're at with respect to social determinants of health. You know, unemployment, we typically double compared to the white population. With a recession, we need to be thinking deeply about what type of jobs we're getting once the crisis is over, what type of jobs we're investing into our communities once the jobs is over. Unfortunately, right now, healthcare is very tied to having a job. So just the whole notion of not having a job can ruin your whole health profile, or if you have poor insurance. So there's an immediate goal of just trying to make sure our community is healthier, but there's also a long-term goal to make sure that we are cognizant of the history of the disinvestment and do something about it, and make sure that we're investing in our communities to sustain and avoid something like this ever happening again.
Dr. Mason?
No, I think I want to thank the 100 Black men for doing this, and we've got a lot of work to do. I'm going to say that I'm going to be as available as I can to help, and I applaud these efforts, but we can fix this because nobody else is going to. And we're going to help save our people, and we want to create more Dr. Walkers and other doctors and everything else, and we can do that.
Dr. Mason.
We got it.
That sounds so very good. We want to tell all of us, all of you that have joined us via Facebook Live, that this particular session will be available tomorrow on the 100 Black Men of Chicago website. So if you missed any of it, we'll have a full version of it available on our website. And this is a weekly series that we're going to take part in. We just scratched the surface of all of the issues that surround this COVID-19 pandemic. We want to give a shout out to all of our first responders and all of those essential workers, and let you know that when it comes to servicing our children, that's why the 100 Black Men of Chicago exist. And I want to thank Drs. Mason and Dr. Walker for joining
Thank
us.
you.
Look forward to seeing you again, same time,
Of course.
if not earlier, next week. I'm Daryl Denard. Have a great evening.
Thank you.
Thank you.
Thanks for having me.